Hello guys, good morning. And today we are going to see about the next chapter, that is diuretics and antidiuretics. First we will see about the diuretics. As you know, the definition of diuretic is a drug that increases the urinary secretion. This is an important drug in our clinical practice because one time or other in our practice we are going to use this drug, whatever the specialty it may be. Further, you should know about the pharmacology of diuretic and what are the types of diuretic and what are the indication and how to handle the drug. So we will see one by one. Before going to the chapter, we have to see about the anatomy and physiology of nephron. So only you can understand the concepts and how the drug act and everything. Just to recollect, you would have studied in your physiology that anatomy and physiology that the nephron is the cell of the kidneys, and each nephron is made up of three parts, mainly the Bowman's capsule, which contain the capillaries, and then the tubules, the distal convoluted tubule, proximal tubules, and then loop of Henle, ascending and descending ascending loop of Henle, in the distal convoluted tubules, and finally the collecting tubules. So these are three main part of the subdivisions regard the where the urine is filtered, and filtered urine is reabsorbed and a part is excreted. So here in the glomerulus we have rich in capillaries. The plasma is separated and the glomerular filtration takes place, and the filtered urine passes to the proximal convoluted tubules, where you have the renal epithelium, which drives the sodium and water transport. So the proximal tubule, the sodium flows down the concentration gradient, and you have the sodium potassium ATPase in the membrane, which absorbs the sodium and water, potassium, and this water flows passively, whereas the sodium and potassium is absorbed against the active sodium concentration. So 67% of the water and sodium are reabsorbed. The remaining goes to the loop of Henle. So loop of Henle, you have what is we have heard studied in the physiology. There is a counter current mechanism. So you got a counter current multiplier mechanism where the distal loop of Henle, descending loop of Henle is permeable to water but not to sodium, whereas the ascending is impermeable to water but transport the sodium. The difference in permeability creates what is known as a counter current multiplier. This is responsible for 20% of the filtered sodium is reabsorbed in the ascending loop of Henle, and some amount of water is reabsorbed. The remaining urine goes to the distal convoluted tubule, where you get 5% of the filtered sodium load is reabsorbed, and this segment is mostly impermeable to water. So we have various segments in the tubules which are permeable to sodium, water, or sodium only to sodium, only to water, and all those things. So then finally the cortical collecting ducts. So here the water is highly permeable to water, and this water permeability is controlled by ADH, which you are going to see the hormone. Last class we discussed about the ADH, and this is where the collecting tubule, the ADH, acts. The driving force for the water reabsorption is created by counter current multiplier mechanism. Here, 2 to 3% of the filtered sodium is reabsorbed and regulated. This reabsorption of sodium and water is regulated by the hormone aldosterone, which you already seen in the RAS pathway. So this is a major site of potassium excretion. Remember, here the sodium is exchanged for potassium, and the potassium is excreted in the urine. So this is brought about by the hormone aldosterone, which is secreted from the another hormone from the adrenal cortex. Here again the main area where the ADH and the aldosterone works. So we should know about this because each drug, for example, aldosterone antagonist, ADH receptor, so all of them act at different sites of the nephron to bring about the pharmacological effect. Then we will see about the pharmacology of diuretic. So as I already mentioned, we have two terminologies. One is diuretic, the other is natriuretic. Diuretic is a substance that promotes urinary excretion. Natriuretic is a substance that promotes sodium excretion. Both are a little bit, they go together, but terminology a little bit different. So in the exam, you will very important big question, a lot of oral questions, as well as you can get a short notes. Classify, note it down. Classify diuretics and write about any one of the diuretic. For example, furosemide, thiazide, or potassium sparing, whatever it may be. But the loop diuretic, the high ceiling diuretics, the important diuretic, very commonly used in practice, and all the specialty we use. You are also going to use. I am using it, and everyone is using it in one way or other. So classification, you can see here the high ceiling or loop diuretic where you have bumetamide, furosemide, and torsemide. The thiazide diuretic, you have hydrochlorothiazide, benzthiazide, and clopamide. And potassium sparing diuretic, you have spironolactone, amiloride, and triamtrin. And the osmotic diuretic, you have the mannitol, glycerol, isosorbate. And yet another group of diuretic called carbonic anhydrase inhibitor, drug known as acetazolamide. Though this is classified under the diuretic, this is not a real diuretic. And these acetazolamide is used for some other indication by the ophthalmologist. Will come after in due course. Coming slides, I'll tell you where they are going to use acetazolamide. Though it is a diuretic, but it is not used as a diuretic. So then thiazide-like diuretic, indapamide, metolazone is a potent, very potent diuretic, and zipamide and chlorthalidone are other drugs. So whatever are indicated in the blue, dark blue color, they are very commonly used diuretic in practice. The remaining are also available, but compared to others, this is a very commonly used diuretics. Then we will see one by one, we will see about the thiazide diuretics. So thiazide diuretic are called low ceiling diuretic because it's not that much potent, but it has got its own action. So what is the mechanism by which, what's the pharmacodynamics, what's the mechanism by which this diuretic acts? So this thiazide is freely filtered and secreted in the proximal convoluted tubules. This drug when taken inside the body, it goes to the circulation, it's freely filtered and secreted in the proximal convoluted tubules. So this binds to the sodium chloride co-transporter mechanism which is required for the active transport of sodium and chloride. So here thiazide impairs the sodium and chloride reabsorption in the early distal tubule as well. So here this drug is going to act in the proximal tubule as well as in the distal tubule. So it is going to prevent the sodium chloride co-transporter mechanism, thereby preventing the sodium absorption. So there will be natriuresis. For every molecule of sodium, one molecule of water will be drawn. So there will be diuretics and there will be natriuresis. So increased sodium excretion is due to increased urine flow per se, and increased sodium potassium exchange, and increase in the aldosterone release. So all these three mechanisms, when thiazide is taken, so there will be an increased potassium loss. So remember, for all the diuretic, the major adverse reaction is electrolyte imbalance, because here the sodium, potassium, everything is lost in the body, from the body through the urine. So there will be severe electrolyte imbalance, hyponatremia, hypokalemia, and hypochloridemia, whatever it may be. So we are going to see about all these things in subsequent. Remember, if a question is asked in the orals, what is the important adverse reaction of diuretic? You tell it is electrolyte imbalance. The remaining adverse reaction we will see. But the important thing is, over all the diuretic, majority is the electrolyte imbalance. Then the whole body effects of thiazide. So increased excretion of sodium, chloride, potassium and water, producing diuresis, natriuresis. So it reduces the extracellular fluid volume. Since the water is lost in the body, the blood volume shrinks. So it also reduces the blood pressure. As you know, already we discussed, the blood pressure depends upon the stroke volume into heart rate. The stroke volume depends upon the blood volume as well as the heart rate. Heart rate and stroke volume into heart rate, and the stroke volume depends upon the blood volume. So once the blood volume comes down, the blood pressure is also comes down. So there will be reduced GFR. So once the blood volume decreases, the blood flow to the kidney decreases, again it is going to decrease the GFR. So this mainly we have seen in the antihypertensive drug, dealing with the antihypertensive drug, thiazide is used as a potent antihypertensive drug. This is another indication for the thiazide apart from being a diuretic. It's a potent antihypertensive. So it is used alone or in combination with any of the drugs, the ACE inhibitors, AT2 blockers, whatever it may be. Thiazide is used in combination with those drugs. And then the pharmacokinetics. So most of the thiazides are orally administered. Though the absorption is poor, they are mainly orally administered. Diuresis occur within 1 hour. The half-life varies with drug to drug. But the chlorothiazide is about 1.5 hours, whereas the highest is the chlorothalidone, very potent and long-acting drugs, 44 hours, more than a day, nearing 2 days. So this chlorothalidone is used to treat resistant hypertension, where you need a more diuresis and more fall in the BP. We use this chlorothalidone. Next, the therapeutic uses of thiazides. So this any diuretic is used to decrease the blood volume. So decrease the edema. So edema due to congestive cardiac failure. Already we discussed essential hypertension, treat any hypertension. Then diabetes insipidus. You will be wondering why this thiazide is used to treat diabetes insipidus. Because diabetes insipidus already there will be increase in the urine flow due to ADH deficiency. In that situation, if you use diuretic, it will produce further urine flow. So today's assignment is today's assignment, because I am going to tell this answer in the next class when you take this antidiuretic hormone. Before that, you have to respond in the Google classroom. What is the significance of using this thiazide in diabetes insipidus? What is the pharmacology behind that? We call it as a paradox. What is a paradox behind that? Everyone should respond below. I am going to put the slides, so everyone should respond with your answers. The next is hypercalciuria. These are a few indications for thiazide diuretics. And diabetes insipidus. So paradoxical reduction, how? Explain. Then use in hypercalciuria. So hypercalciuria is one of the important cause for the recurrent calcium stone formation, renal stone formation. So this thiazide promotes the distal tubular calcium reabsorption. So once the calcium is reabsorbed, that will prevent the excess excretion, when there is excess excretion of calcium in the urine, that will go and deposit in the urinary tract and can produce renal calculi. So 50 to 100 milligram of hydrochlorothiazide per day. The patient kept this patient stone free for 3 years and follow up. Recent study says that if you use low dose of thiazides for those patients who are suffering from renal stones, it will prevent the formation of recurrent renal stones. Adverse reactions of thiazides. In hypokalemia due to increased potassium excretion, hyperuricemia because the urate is prevented from excretion, and hyperglycemia because this decreases the insulin secretion related to the potassium. See, as you know, we have studied in diabetes, the closure of the potassium channel and opening of the calcium channel is required for insulin secretion in the beta cells. So here, since the potassium ions are very much decreased, the normal insulin secretion is inhibited. So it can lead to hyperglycemia, so drug-induced diabetes. So elevated plasma lipids, not only thiazide per se, for any diuretic, will lead to dyslipidemia. So two important adverse reactions of thiazide is, one is the electrolyte imbalance, another is dyslipidemia. For any diuretic, I can tell these two. Then the next topic will be the loop diuretics. It is an important diuretic called high ceiling diuretic. So this loop side diuretic are called high ceiling diuretic. You have furosemide, commonly used as Lasix furosemide, then bumetanide, torsemide, ithacronic acid. So among this, the furosemide and torsemide is available in the market. The remaining two drugs are mainly the drugs used for research purpose. So here the mechanism of action is it enters the proximal tubule via organic transport, active transport. There thiazide is freely filtered. Here it enters the tubules by active mechanism, organic acid transporter mechanism. So it inhibits the apical sodium potassium chloride co-transporter of the ascending loop of Henle. As you know, the ascending loop of Henle, we have more sodium reabsorption due to countercurrent mechanism. So sodium absorption is very high. So the competitive chloride ions for binding. So this competes the chloride ions for binding. So it inhibits the sodium potassium chloride co-transporter mechanism. Thereby it promotes the excretion of the sodium, potassium, water, chloride. Again, is going to produce the hyponatremia, hypokalemia and hypochloremia. Then pharmacological effect of loop diuretics. So loss of diluting ability, so increased sodium, chloride and potassium excretion, and loss of concentrating ability, reduction in the medullary osmotic gradient, loss of ADS directed water reabsorption in the collecting tubules, and there will be loss of ascending loop electrostatic driving force, increase in the electrostatic driving force of cortical collecting ducts. So all this net effect will lead to excretion of the sodium, chloride, potassium and water. So all the electrolytes including the water is driven away. So it's called high ceiling diuretics. The potent diuretic available among all the diuretics is a very potent diuretic, and most of them are so here you have the tablet as well as the injection form. Injection is always given by intravenous route, not by intramuscular. Remember, laxative is given by intravenous, furosemide, torsemide, whatever it may be. And absorption is very, very good orally. About 65-100% is absorbed. The onset is very rapid, and they are extensively bind to plasma proteins, and they are secreted by proximal tubule organic acid transporter mechanism. I mentioned this. In therapeutic uses, all the edema, cardiac edema, renal edema, hepatic edema, water pitting edema, where there will be excessive collection of fluid in the third space. If we use this diuretic, it will lead to decrease in the edema. And number 2 is acute pulmonary edema. As you know, name indicates, the pulma means lungs. Accumulation of fluid in the lungs, where you can use the parenteral route, you can get a dramatic effect. It's a life-saving drug. And chronic renal failure, where we are going to use this drug as a tablet form for a long time. And sometimes, very rarely in hypertension emergencies, along with the other drug we can use it, but thiazides are more indicated for hypertension than the loop diuretics. And use in symptomatic hypercalcemia, again due to driving away the calcium in the urine. You are going to use this in the hypercalcemia. Then loop diuretics toxicity, again the same thing, the electrolyte imbalance, hypokalemia, magnesium depletion, chronic dilutional hyponatremia, metabolic alkalosis, hyperuricemia, autotoxicity. So here autotoxicity produces deafness, so neural type of deafness. So diuretic, for loop diuretic, they ask the adverse reaction, major 3. Number 1 is electrolyte imbalance, number 2 is autotoxicity, number 3 is hyperdyslipidemia. Then drug interaction. So the lithium clearance is decreased, and so it can lead to, as you know, lithium is a drug with low therapeutic index. So when the patient is on lithium, do not use loop diuretics. And number 2 is other autotoxic drug. For example, we have studied the aminoglycosid antibiotics, produce a potent adverse reaction like autotoxicity. So in those combine, we should not combine this drug with particular aminoglycoside, where both of them they have additive effect in producing a severe neural type of deafness. And the next is so very commonly used drug for almost, this drug is also used to drive away the poison. So those drugs which are excreted in the urine for drug toxicity or drug poisoning, diuretics, when you are forced to use diuretics, we are going to use this loop diuretics, particularly the furosemide promotes the excretion of the other drugs in the urine. Then the potassium sparing diuretics. As you know, potassium is lost in all type of diuresis. So it will lead to severe hypokalemia. Severe hypokalemia will lead to a lot of cardiac problems, sunken eyes, husky voice, cardiac ECG changes, sometimes lead to fibrillation and cardiac arrest. So we don't want this to occur. So you are going to use this potassium sparing diuretics along with the other diuretics, or can use alone to prevent the severe hypokalemia. The one drug is the spironolactone, where the mechanism of action is similar to is aldosterone antagonist. Already we discussed in the distal tubules, where the ADH and aldosterone is going to act in the collecting tubules and distal tubules. So here this spironolactone is the aldosterone receptor antagonist. So this spironolactone prevents the conversion of receptor to the active form, that is aldosterone receptor to the active form, and that way preventing the action of the aldosterone. So this aldosterone is a hormone which is going to exchange the sodium for potassium, and here since this exchange takes place, so if for every molecule of sodium excreted, this potassium is going to excreted. So this sodium potassium ATPase activity is inhibited, so potassium is not excreted. What is the mechanism of action of this potassium sparing diuretic? Is your spironolactone. Then pharmacokinetics. So 70% of the absorption takes place in GIT, and the extensive first pass metabolism in the liver has got enterohepatic circulation, extensively bound to plasma protein, 100% metabolite in urine, and the active metabolite is called carninone, and carnate is converted to carninone. This is excreted in the urine. So mainly metabolism takes place in liver, excretion through kidneys in an active metabolite form. In uses, it prevents a potassium loss caused by diuretic. For example, if you are going to use thiazide diuretics or your loop diuretics, along with this you can use this spironolactone in hypertension, refractory edema, heart failure, to prevent potassium loss. And primary aldosteronism, where there will be excessive secretion of aldosterone that will produce severe potassium hypokalemia, we are going to use this spironolactone. So dose is 100 mg per day. The severe adverse reaction is again the other way around. When they use the excessive dose, it can produce hyperkalemia. So androgen-like effect due to the steroid structure. When you use this drug in a long run in a male, it can produce gynecomastia, enlargement of male breast, GI disturbance. These are three important adverse reactions of this spironolactone. The other two drugs that belongs to the potassium sparing diuretics is triamcinolone and amiloride. So these are potassium sparing, but that doesn't have a steroid structure. If we have taken this spironolactone, it has got a steroid structure, whereas this triamcinolone and amiloride are similar to the potassium sparing diuretic spironolactone, but no steroid structure. So it is not an aldosterone antagonist, it acts a different mechanism. So it produces the apical blockade of apical sodium channel in the principal cells of cortical collecting tubules. So the amiloride blocks the sodium potassium exchanger mechanism, sodium hydrogen exchanger mechanism, and the blockade of this lead to electronegative electrogenic entry of the sodium, cause a drop in the apical potential. This become less negative. So which is driving force for the potassium secretion. So this electronegativity, which is going to drive away the potassium in the cortical collecting tubule, is blocked by this amiloride and triamcinolone. So here this triamtrin amlodide is given by oral route, and again the extensive metabolism takes place in the liver and excreted through the kidneys. So again same indication as spironolactone. For those we need diuretic, but we don't want to hypokalemia. Along with the diuretic, or can be used along with the loop diuretic, or can be used to as a diuretic, and which will prevent the hypokalemia. So again other way around, the same thing, hyperkalemia. So here drug interaction, as you know, this drug should not be used along with the ACE inhibitors. And triamtrin very rarely it can produce nephrolithiasis and azotemia. These are all very rare, but should not use AC particularly this potassium sparing diuretics along with ACE inhibitor, because it will worsen the situation. With this we finish the part 1 of the diuretics, and we'll continue the session in the next class with the other diuretic, what are the remaining diuretic left off. Okay, have a nice time. You do the assignment and you record the assignment, that is why you are using this particularly the thiazide in diabetes insipidus. You respond with your answers, then we'll meet in the next class. For attendance, for your attendance, I'll put this video which you are watching. In that you have to respond. In the response you write your name and write your response. Say thank you or good morning, whatever it may be. So that is your attendance. It's going to be attendance here. Thank you. Bye.